So Dr. Heidelbaugh, besides looking at genetic risk factors for the African-American population and active surveillance, what do you think about other aspects of helping to choose a patient best for active surveillance? Are there certain screenings that you think need to be done as far as their, say, their mental status and overall health and well-being, if they're emotionally good candidates to be on active surveillance or not? And do you have like certain counseling techniques that you use when somebody is trying to make the decision of active surveillance versus intervention?
Sure. So a lot of it goes back to what Dr. Powell said before. Obviously, looking very comprehensively, you're going to want to risk stratify any man who, for potential active surveillance, to look at their cardiometabolic profile. You want to look at their other chronic illnesses. I've had patients with life-threatening conditions where the prostate cancer becomes secondary or tertiary compared to the other things going on for them. You know, I'm thinking end-stage cirrhosis. I'm thinking hematopoietic diseases. I'm thinking of a variety of other different things. Obviously, cardiometabolic is one of them. With regard to mental health, yeah, I think any man who's offered active surveillance has to understand what that means. The analogy I always use is prostate cancer for many people is going to be one of those cancers, especially if you're at a Gleason 3+3/6 stage for active surveillance, where you're going to need a lot of checking in, and you're going to need a lot of checking in points to be able to say, how are you doing? How's your overall mental health state? Are you anxious? Are you depressed? What are your support systems? And what questions do you have? It's very hard to tell someone you have cancer, but we're not going to do anything about it. There aren't a lot of other cancers where we do that. Most other cancers, when we tell a patient they have cancer, we're going to walk out of the room and book an appointment with an oncologist that afternoon or the following day, because that's what we do. So the active surveillance piece, I think, is not only multifactorial in terms of looking at chronic diseases and chronic illnesses, but an assessment of mental health status, and also all of the social determinants and support systems that a patient has.
Yeah, and it's not the American way not to treat it. So like you said, it's really hard to tell somebody we're going to watch it and to say we're just going to treat you like we treat hypertension as a chronic disease. Doesn't have the same feeling. It doesn't have the same gestalt or sense when you say that.
I think you also have to balance that with, in any case, what a patient knows. I find more and more, all of my patients have figured out how to read the internet and figured out how to find out information. And so when they come in and they say, okay, you're going to do what? They know something about what we're going to propose, or they know something about what they've read or what they've heard from a family member or at work or a church group or a social group. You probably don't have too many degrees of separation with most men where they don't know someone else with prostate cancer or haven't heard about somebody else's prostate cancer experience.
Plus, there's a lot of Google searches. I mean, I have patients who come in all the time and say, I apologize, I did a Google search. And I think, I go home, I do Google searches.
Absolutely.
So I call Dr. Google all the time. Really smart doctor.